let's go back a little bit, and we've kind of briefly talked about TDM1, and I clearly, let's talk about TDM1 actually first in the second line setting, and we're lucky to actually have sitting to my right the principal investigator of that trial. And so Kim, what are your thoughts about EMILIA, and how does it really change our therapy for second line therapy in HER2-positive metastatic disease?
Well, I mean, today the results of EMILIA with a 5.6-month improvement in overall survival are still impressive for second-line metastatic breast cancer. It's important to note that no women on the EMILIA study had received pertuzumab, so you could say, well, we can't necessarily apply it to women who get pertuzumab in the first-line setting. But even with that, the therapeutic index is still quite strong for the use of TDM1 in the sense of very few chemotherapy-related side effects. The mechanism of the thrombocytopenia has actually been worked out, and it's published about a month ago in November's Clinical Cancer Research. So it's a gamma receptor that the TDM1 binds to.
Really?
On the megakaryocyte, and so I'd encourage people to go to that paper. And
that's very interesting.
What's also interesting is this gamma receptor is differentially expressed based on ethnicity. It's a low binding affinity gamma receptor, so depending on the ethnic group you're treating, it looks like it's more highly expressed in Asian populations, maybe explaining the little bit of data we have that thrombocytopenia might be more common in the Asian population. So just something to be aware of. It's worked out, it's not some mystery. And so just be aware of it. Encourage patients to report easy bruising, bleeding, even if they're on an anticoagulant. But other than the thrombocytopenia, and we do see some bumps in the liver enzymes in a little over 10% of the patients, very well tolerated, and a survival advantage. So it's hard to imagine that you wouldn't want to use TDM1 in the second line setting.
So let me ask you a question, because you also were the principal investigator of another trial of a regimen that everybody uses, which is lapatinib and trastuzumab. So when do you use which one? I mean, that's sort of, do you even use the combo at all?
So remember, the median number of cycles trastuzumab containing regimens in 104-900, which is lapatinib tras versus lapatinib, was 4.5. This was these were as addicted to HER2 tumors as you could get. So I certainly wouldn't use it in the first line setting, the combination of lapatinib, trastuzumab. I wouldn't use it in the second line setting. But it's worth considering the third line setting, especially if there has been a meaningful duration of HER2-based therapy responses. And around the second line setting, I'll tend to rebiopsy. Loss of HER2 is almost unheard of. But for patients who didn't have a good response in the first line setting, didn't have a good response in the second line setting, it's probably worth rechecking the HER2 around that time, because if you put a patient on lapatinib and trastuzumab, you're making a pretty generous assumption that that is a very HER2 addicted tumor. Otherwise, it will not work.
Yeah, I mean, that's really the question, rebiopsy. And I really thought of rebiopsy in the setting of, well, someone's never had anti-HER2 therapy, and maybe was kind of borderline, maybe had a ratio of 1.5 or something like that. Does anybody ever rebiopsy to prove HER2 status, try to get someone on trastuzumab or anti-HER2 therapy?
Yeah, I mean, I think we're seeing, or at least the debate is whether heterogeneity of tumors exists de novo, and there are subclones that could be positive, and those are the ones that outgrow after you use other therapy. I mean, I think it's a debate. We don't know, but I think in the clinic, we see that. I'll give you one quick example. A patient who was on about third line of therapy, and we rebiopsied her, and she became HER2 positive, and I wasn't sure. I gave her first line therapy, and then I gave her TDM1, and she responded. So technically, she had to be HER2 positive to respond to TDM1. Yeah. Clinically, it wouldn't have worked in that setting, and that was an interesting proof of principle to me.
So the final question, I think, before we move on with this, is what are people's thoughts about TD1 in the first line setting? I know we have the EMILIA trial, and I'm curious to hear people's reactions to what they think that's going to show. Ruth, what do you think of EMILIA? Maybe talk about what the design is for people who may not know it.
So it is basically looking at pertuzumab plus TDM1 versus, somebody help me here, TDM1 alone versus the docetaxel trastuzumab.
Correct.
So I think, certainly the results are going to be interesting. The problem, I think, is that the control arm of the CLEOPATRA regimen is not in there, so it's going to be a problem with regard to that. But obviously, if we see a marked benefit for TDM1 and pertuzumab, which looks like it's more than what we see Cleopatra, which would sound a little bit unlikely to happen. I think maybe we would start doing that. But you're also going to run into the issue of, is it better to start with a pertuzumab-based regimen, go to TDM1, or give them both together? And I don't think we're going to know that answer either. So I think it's going to bring up quite a lot of questions.
I think that's the biggest issue. I'm curious if people, what would happen if, my fear of this trial is TDM1 is maybe better than the control. I think that, at least in terms of toxicity, we don't know. But the real issue is, what will pertuzumab add to TDM1? Any thoughts? What do you think? We don't know. We're speculating. We have no idea.
So I think the combination of pertuzumab and TDM1 is probably going to be better. But for me, I still go back to the 15.7-month improvement in overall survival with chemo, pertuzumab, traz. So unless there's a tremendous survival advantage to adding TDM1 to pertuzumab in the first-line setting, I probably will continue my practice of taxane, traz, pertuzumab, taxane, traz, pertuzumab in the first line, and then TDM1 in the second-line setting. I'm an outlier in that, but again, it's hard to deny patients a 1.5-year survival benefit.
But won't it, Rich, take a long time to get the survival data from Marianne?
Well, sure. But keep in mind, Cleopatra was largely a trastuzumab naive population. The other thing, as we talk about, a lot of these drugs are aimed at overcoming HER2 resistance. The TDM1's mechanism appears to be totally independent of signal transduction, of all the mutations, PI3K mutation, things that have been put forward as mediating resistance. So this combination of TDM1 and pertuzumab, I'm not sure what the benefit's going to be, basically because TDM1 is just a potent deliverer of a cytotoxic.